Hello and welcome. I'm Dr. Dhiren Patel. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for today's educational activity titled Halting Drivers of CKD Progression. Today's activity is brought to you by CME Outfitters, an award-winning, jointly accredited provider of continuing education for clinicians worldwide. And this educational grant was supported by Bayer Pharmaceuticals. During this presentation, I want to encourage everyone to join us today on our live Twitter conversation at CME Outfitters. We will be monitoring the Twitter feed and responding to your tweets as they come in, and feel free to also text and chat your questions as you have them as we go through the presentation. As I stated, I'm Dr. Dhiren Patel, an adjunct associate professor of pharmacy practice at the Mass College of Pharmacy in Boston. Today, joining me is Dr. Bob Busch. He's the Director of Clinical Research at the Albany Medical Faculty Practice in Albany, New York. Also joining me today is Dr. Javier Morales. He's an Associate Clinical Professor of Medicine at the School of Medicine at Hofstra Northwell, and the Vice President and the Principal Clinical Trial Investigator at Advanced Internal Medicine Groups. Thank you both for joining this evening.
Thank you. Thanks for having me.
The first point that we're going to try to tackle today is regarding recognizing when a patient should undergo recommended guideline based screening for both UACR and eGFR for early diagnosis of CKD in patients with type 2 diabetes. So the first thing that I want to do is get everyone involved. As I mentioned earlier, we're going to make this very interactive. And so I want to start by getting our learners involved in an audience response question. So the first question for you is, approximately what percentage of patients with type 2 diabetes develop chronic kidney disease? Is it A, 10%, B, 20%, C, 40%, or D, 80%? So go ahead and vote now. Excellent. So we will share the results in a little bit later on in the program. So we're going to start off talking about our first patient case, and we're going to carry this patient case as we go through this first section. So here we have a 62-year-old male with hypertension, type 2 diabetes, myocardial infarction, EF noted here on the echo from 2 months ago of 40. And is presenting for a follow-up visit. You can see some of the notable medications listed there on the slide. They include an SGLT2 inhibitor, a beta blocker, a statin, aspirin, Plavix, clopidogrel. We have a loop diuretic, and patient has no known drug allergies. In terms of other history, we know that he is a 35-pack year smoking history, stopped about 12 years ago, 3 beers weekly, works as an executive for a shipping company, married, 2 children, 1 grandchild, and walks the dog at least 2 miles twice weekly. You can note the physical exam there, blood pressure 120/70, heart rate 64, and a BMI of 31. Patient's last A1C was 6.8, BUN serum creatinine 36/1.6, LDL 72, eGFR 43, and we have a UACR of 275 on file. So let me ask you, which medication modification to SG's regimen would be most beneficial to delay the progression of eGFR decline and UACR improvement? So your options here are, would you add lisinopril, which is an ACE inhibitor? Would you add finerenone, which is a mineralocorticoid receptor antagonist? Would you change from one SGLT2 to another, so from DAPA to CANA, or change the combination of sacubitril and valsartan to just losartan? Or E, you're not sure, you don't know. Same thing here. We'll look at these results a little bit later in the programming. So I want to get our esteemed faculty involved here. And Dr. Morales, I want to start by focusing on screening. You're on the front lines. You see, everything being in a primary care internal medicine setting. What can you tell us about guideline recommended screening? What do you see? Where are some of the gaps? What can we be doing better?
Well, Dhiren, thanks very much for having me here on this program. I think it's really, really valuable to our audience to start talking about chronic kidney disease and diabetes, because it actually is a lot more common than you realize. In fact, about 38% of patients with type 2 diabetes develop diabetic kidney disease. So the diagnosis of diabetic kidney disease is actually made by the presence of albuminuria of 30 milligrams per gram or greater, and or a reduced glomerular filtration of less than 60 in the absence of signs or symptoms of other primary causes of kidney disease. Sounds like a lot, but it really isn't that much. Now, what's really important here is the fact that all patients with type 2 diabetes, at the very least, need to be screened yearly to see whether or not they're spilling protein in the urine. And if they do have any evidence of protein in the urine, then, in order to really establish that diagnosis, you should have at least 2 abnormal measurements, at least 3 months apart, just to establish that diagnosis. Now, a lot of us order blood tests all the time for our patients, and these include basic metabolic panels in which we get to, you get a calculation of glomerular filtration. So back in the old days, we would use the Cockcroft-Gault equation. I don't know if any of you remember that in the audience. It was like 140 minus the age times the weight divided by 72 times the serum creatinine. And if you were a female, you would have to multiply that by 0.85 to get it. But the computers nowadays do it for you. So what's kind of interesting here about these things is that the GFR is actually used to kind of grade the severity of dysfunction, whereas the albumin or the albumin creatinine ratio kind of gives us an idea in terms of whether or not there might be earlier damage. So all patients with type 2 diabetes, at the very least, should be screened at least once per year. And again, a repeat test a couple of months later if it's abnormal. Now, let's go a little bit more detail in terms of glomerular filtration, because we all know that a normal glomerular filtration is going to be about 100 in a non-diabetic individual, but that GFR actually goes up during pregnancy, as you're all aware. But obviously, during the course of the natural history of diabetes and whether or not there might be some damage to the kidneys as a consequence of diabetes, glomerular filtration actually can go down. And we've actually graded this based on stages 1, 2, 3A, 4, and 5. And again, it's easy to calculate. The machine does it for you when you get a basic metabolic panel. But the urine albumin creatinine ratio is a very special test, because while the urine albumin creatinine ratio, which is typically detected by a dipstick, fingerstick method in the office, sometimes you could do it on some of these laboratory instruments. It is actually the earliest defect that you will see or encounter in patients with chronic kidney disease or evolving chronic kidney disease.
Well, that's excellent. And thank you for that thorough response. And so, one thing that was very clear is, from a screening standpoint, basically all patients with type 2 diabetes, you're going to screen. And so that's a great takeaway there for the audience. And I think, the point that you made here is that sometimes we don't realize that the eGFR is a marker of kidney function, while albuminuria is a marker of kidney damage. And I think the combination is what we need for that prognostic framework. And so with that being said, Dr. Busch, when we think about how we bring this together, we have guidelines and heat maps. And so the Kidogi heat map is something that many of you are probably familiar with and you've probably seen. So if you could describe the heat map for us, and where do you think our patient that we reviewed earlier would fall on this heat map, and give us just a little bit of background regarding the different categories and the stratifications there.
Well, thank you. And I'm pleased to be here as well, and with Dr. Morales and Dr. Patel. So the heat map is the equivalent, sort of like the Framingham score for your patients with cardiac disease. So you use that for a while. So if you had someone who smoked, who had high blood pressure, a family history of heart disease, and high cholesterol, obviously that's someone at higher risk for heart disease than someone, who everyone lived to 90, they don't smoke and all that. Similarly, if you look at the kidney function on the vertical axis and the kidney damage, as was said before, based on the microalbuminuria or albuminuria on the horizontal axis, the darker the red people are at much higher risk. That would be the equivalent of the smoker who has family history, who has whose high cholesterol is very high, and versus someone who is very low risk. So, for example, in the green, you have someone who doesn't have microalbuminuria, whose GFR is fine, stage grade 1. Whereas in the red, you have patients, the further more proteinuria you have, or the worsening your renal function based on the GFR, the more likelihood you are to go on, I would call it the high-speed train to dialysis. And what we're going to talk about is flattening the curve. Instead of going to dialysis over a short period of time, you flatten the curve and you benefit their kidneys. And a lot of what we'll be talking about is not only the cause of this, but what we can do about it. And now there's a lot of what we can do about it where there wasn't years ago. Just like years ago, there was not much you could do to prevent heart disease. And then not only do you have statins, but you have fish, certain fish oils like icosapent ethyl, and you have blood thinners, et cetera. Same here with kidney disease. We have lots of things we could do from preventing you from progressing from orange to green. Now, where does the patient fall? So as said in the case, he had a GFR of 43. So going on the vertical axis, he would be a stage 3B chronic kidney disease. And then going on the horizontal axis, his urine micral was 275. So he'd be in the middle there, A2. But if you look at A2 going down to 3B, you're red. So those patients are at very high risk to go on to dialysis unless you do something, and you're going to better do something quickly and not wait about it. And very importantly, you should inform the patient that they have kidney disease, because the patient has no symptoms of that, right? If they don't have edema and they're not seeing a nephrologist, how do they know they have kidney disease unless we tell them? And as you'll hear later on, a lot of people don't know that they have kidney disease. The majority don't know they have it unless they're seeing a nephrologist or on dialysis. So it's very important for all of us to inform the patient.
Absolutely. And before we even get to the identification of CKD, and I think you bring up a really great point that I think CKD is one of the under-recognized public health crises that we have here in the US. And before we go into that, I have a couple follow-up questions for you, but we have one question that has come in. And as we said today, we're going to make this very interactive. So please, as questions come in, feel free to type them in. The first question that we have, and it relates to this last few slides, Dr. Morales and Dr. Busch, you've covered. So I want to ask now, the question is a spot urine albumin test just as accurate as a 24-hour urine test? And why would you ever want a patient to do a 24-hour test?
That's a great question. So thanks for asking, for whoever asked that question. So for the most part, spot urine albumin creatinine ratio just tells you whether or not there might be evidence of microalbuminuria in the urine. However, if we're doing a full 24-hour urine collection, we're actually measuring the specific amount of protein that's built in the urine. So a 24-hour test winds up being extremely important, particularly if we're looking for things like multiple myeloma or nephrotic syndrome. Now, we do know that patients that do have type 2 diabetes do develop nephrotic syndrome. But by that time, the horse is way out of the barn and it's already circling the second time around the track. So the key thing is using the urine albumin creatinine ratio in order to detect earlier whether or not there might be some filter damage in which there might be some protein spilling in the urine, so that you can implement more appropriate therapies in hopes of curtailing this progressive renal failure.
Thank you so much, Dr. Morales, for that. Dr. Busch, going back to identification of CKD, and you've have a lot of pharmacists in your practice, and you've used pharmacists in very creative ways, everything from clinical trials to patient care. And I know this is an area where pharmacists have been crucial in flagging to see if patients don't have a UACR. But if you could talk a little bit about just the identification, and you kind of were going into that, of patients don't know that. And when we compare them to, let's say patients with a diabetes, like 80% of patients know that they have a diagnosis, or, we look at high cholesterol and 70% of folks are on a statin. But, why is that so different when it comes to CKD here?
Because it's silent. The patient doesn't know they have it unless they get edema or unless they refer to a nephrologist. So, people who have heart disease know they have it. People who need a cholesterol drug know that what their cholesterol is, like know your number. Even A1C, people know their A1C and they know they have diabetes. Obesity at one time, unless people knew their BMI and what that meant, of a little overweight, but, we have BMI now, we know what that means, overweight or obesity. With chronic kidney disease, we should all be in the habit, we're a team to do this. As one who recruited for studies where I looked at our database and looked at patients who had urine microalbumin and GFR, and I'd be calling the patient, say with my partner's patients, a lot of times they were shocked. What do you mean I have kidney disease? I'm recruiting them to be in a study to be on a kidney protective drug on top of their RAS blocker, and they didn't know they had it. So it turned out to be a 20-minute conversation to someone that they thought, oh my God, I have kidney disease. I'm going to go on dialysis. So having any of these stages doesn't mean you're going to go on dialysis, but you want to prevent that. And as you can see some of the data here, the key thing on the header, 9 out of 10 people don't know they even have kidney disease. Now, though, if you have more severe kidney disease, and particularly if you had a nephrologist, you might know you have it. But even that, the majority of patients don't know they have chronic kidney disease. So when it comes down to when you're doing your diabetes exam with someone, eyes, heart, kidneys, feet, you see, unlike Dr. Morales, we have it very easy. We have to know a lot about a little. He's primary care. He has to know a lot about a lot. Did you see the eye doctor? When I come to heart, are you on a statin? Are you on a ACE or ARB? Is your blood pressure down? Kidneys was, do they know that they have kidney disease, and don't take an NSAID or a COX-2 and keep well hydrated. But importantly, let them know that they have kidney disease. And it doesn't have to be the physician. It could be the pharmacist. It could be anyone on the care team. But that's very important that the patient is aware of that. And you see the data here. In my own experience, out of the phone calls I was making, 1 out of 10 knew they had it. It was burdensome to recruit these patients because it was a long conversation to inform them and reassure them that no, just because you have kidney disease doesn't mean you're going on dialysis. The whole goal is to prevent this from going on. So,
that's a great point. And I think talking about some of that potential benefit of slowing that progression of CKD, everyone just assumes the end-stage kidney disease is kind of where it's going to go. But what are some of the benefits of slowing this CKD progression other than the obvious?
So people who have worsening GFR or a worse stage, if you go from left to right on the horizontal axis from green to yellow to orange to red, look at the vertical axis. This is hazard ratio for dying of heart disease. So people who have kidney disease have heart disease. In fact, in some of the companies, when you recruit for a study that's for cardiac patients, not only are you looking for stents and angioplasties or stents or events or MI, but you're looking for CKD where the GFR is below 60, they're considered cardiac risk equivalent. So walking in the exam room with someone who has a GFR below 60, you're thinking this is a person at high risk for heart disease, and the data is shown here. As you go from right to left, as the worsening your GFR, you're going upwards in terms of dying of heart disease. And you'll notice when we do some of the renal studies later on, that these patients have very high risk of heart disease and dying of heart attacks and strokes. And in addition, not on the slide, the worsening your albuminuria, the more damage to the kidney, not only the worsening your kidney function, as was said with GFR, but the worsening your albuminuria, also you increase the rate of heart disease. What goes on in your urine reflects what goes on in your endothelium elsewhere.
Well, that makes sense. And we have a question that's come in. We've had a lot of questions come in, and I know we're going to be covering some of this as we go through the presentations. And so I'm going to try to park them in the right area so that way we can discuss them. We have one here that Dr. Morales, you mentioned pregnancy for a little bit. So I'm going to ask you here, a pregnant woman that develops preeclampsia, are they predisposed to kidney disease later in life? Is it kind of like, diabetes, where if they have gestational diabetes?
That's a great question, and regrettably, I don't know the data with respect to the relative number or the incidence of developing chronic kidney disease in the presence of preeclampsia. But I do know that it does get better following delivery. But as mentioning with gestational diabetes, half of patients that do suffer with gestational diabetes go on to develop full-blown diabetes later on in life. Mm. But I'm unaware about the kidney and whether or not it is chronic kidney damage that they do develop. I don't know, Bob, what do you think?
Yeah, no, I don't know. I don't know that either.
Okay, that's a great question, and we'll come back to you on that one. But like I said, as we know with some of these other conditions, it usually is some type of risk factor, but we'll be sure to get back on that one. So hopefully what you've seen here in this first segment, and we're going to have a series of 2 other segments, we talked a little bit about the screening and why that's important, and that's going to lay the groundwork for what we're about to go through in these next 2 segments. And what we want to focus now on is the pathophysiologic features of CKD that's giving rise to renal, CV, mortality risks in patients with CKD and type 2 diabetes, despite optimized management. And we're going to talk a lot about standard of care. I have probably about 4 or 5 questions that have come in regarding CV discussions, CV benefit of other medications. And so we're going to get to all of those. But what we want to do is make sure that everyone appreciates kind of the pathophysiologic features and what we're actually, solving for, so that when we talk about the pharmacotherapy agents, it's going to, be that much clearer. So I want to start off with another question. And the question here is, which of the following theories may cause CKD in a patient with diabetes? So is it A, overexpression of IL-5, B, increased mesangial contraction, C, overexpression of mineralocorticoid receptor, D, podocyte fusion, or E, I'm not sure, I don't know? So we'll review these results as well a little bit later in the programming. So Dr. Morales, could you walk us through, we just had a great segue of contributors to CKD in our patients. What are you seeing, whether it be, lifestyle or otherwise? We actually had a question come in around cigarette smoking. So if you want to take that one, what are the contributors in your mind, and how do you kind of work through those progressions?
Sure. So, the association of chronic kidney disease and what causes chronic kidney disease, wow, it's kind of complex because it is a big bag of physiology. So I guess first, let's take a look at the more common causes of chronic kidney disease. And aside from elevated blood pressure with elevated filtration pressures that pop nephrons, you also have type 2 diabetes. And typically with diabetes, you get deposition of glucose within the glomerular areas. And we all know these as Kimmelstein-Wilson changes, and ultimately leads to poking holes through the whole filtration system. But infections can sometimes do it with circulating cytokines and activation of supportive tissue within the kidneys themselves. Certain medications that are taken in excess can contribute to kidney dysfunction. The classic is always going to be the nonsteroidal drugs. Now, the nonsteroidal drugs, aside from creating structural damage by papillary necrosis, as we all recall, the nonsteroidal therapies do inhibit cyclooxygenase, which is responsible for prostaglandins. The mesangium, which regulates flow and filtration within the kidney, is actually dependent on those prostaglandins. So if you're inhibiting prostaglandins, then what happens is you get mesangial contraction, which decreases the GFR. And then, of course, there's toxins that can contribute to diminished glomerular filtration. But more recently, we've discovered the renin-angiotensin system and how the renin-angiotensin system can actually impart significant impact with respect to the heart and with respect to the kidneys. And if we look at the renin-angiotensin system, it all starts with angiotensinogen, which then goes to the liver and then becomes angiotensin 1, which then goes to the lungs to get activated to become angiotensin 2. And that angiotensin 2 is probably the most potent vasoconstrictor that we have, that we are aware of at this point in time. But more recently is the fact that all of these all interact with what we call mineralocorticoid receptors. And this is basically where this renin-angiotensin system actually exists. So what we've learned over the years is the mineralocorticoid receptors actually exist in multiple organs, including the heart and including the kidney. And if we look at the mineralocorticoid receptor at the level of the heart, well, it could be responsible for cardiomyocyte growth and maybe even some electrophysiologic principles. But what we've learned is that in the kidney, in certain disease states like diabetes, there tends to be overexpression of these mineralocorticoid receptors. And when you do have this overexpression of mineralocorticoid receptors, it could actually lead to fibrotic changes within the kidney and can speed the process of chronic disorders like diabetic kidney disease. So I know I said a mouthful, I gave you a lot of physiology, but I think what we're getting at is the renin-angiotensin system and overexpression of those mineralocorticoid receptors and the contributions that they can have on end organ damage.
Oh, that's perfect. And I think walking us through the contributors, I think, was a great one. And I know Dr. Busch has mentioned this in the past of the entire care team. You know, a lot of those contributors, you have various folks on the care team. I know we have a lot of pharmacists on the line today, but you brought up a really big one, medications. And that's something where Dr. Busch, maybe you can speak to a little bit. You have pharmacists that are integrated into your practice, and I know they help you out in terms of screening and looking at some of these medication lists.
Right, and very importantly, as was mentioned by Dr. Morales, the NSAIDs, that's a big ticket item. Mm-hmm. Primary care, and not Dr. Morales, but many of our colleagues use a lot of NSAIDs and COX-2s, and these are the very drugs that are nephrotoxic. The first thing in a nephrologist's note, word processed in their note, is no NSAIDs, no COX-2s. And as a pharmacist, these patients might be taking over-the-counter drugs. They could be filling their ARB and their SGLT2 and whatever else to benefit their kidneys, and there's their Aleve that they're buying at checkout. So you could really save their kidneys by discussing this, and that a lot of people don't know that. And a lot of physicians don't ask about over-the-counter drugs, but you're the one, if you're in retail, seeing it purchased, or if you're the pharmacist in a clinical practice, asking the patient what are the supplements they take and, you know, that they're taking NSAIDs. And importantly, warning patients not to get X-ray dye studies. If you have kidney disease, you go to the hospital and you have an IVP because of a kidney stone, you could be in an acute renal failure the next day. So those are the kind of things to review, as well as keeping good hydration status. Remember, here, since we have the kidneys and the heart on the slide, the kidneys want to be wet, the heart wants to be dry. That's how they interact. So if you have heart failure, you're worsening your kidney disease. If you have kidney failure and you're retaining fluid, you're worsening heart failure. So they interact in many ways because of the common modality of these hormones.
Yeah, thank you so much. And that makes a lot of sense. And an area that I want to focus a little bit more on, and we'll give a little bit more context to some of the more common conditions, is to walk you through a short video discussing the drivers of fibrosis and kidney damage. And so here you'll see in the video that normally the kidneys act to filter the blood through a nephron. And patients' normal GFRs are usually above 60. And then patients you heard in today's presentation have hypertension or diabetes may get kidney damage. And during hypertension, what happens is these vessels thicken and there's this narrowed path where that blood enters an afferent arteriole. And so that's one reason you see a decrease in GFR. A decrease in GFR then increases renin. Dr. Morales talked a little bit about this pathway, which activates the RAS system. And the RAS activation ultimately leads to glomerular necrosis, which leads to ischemic injury and the loss of that nephron. So you can kind of see those drivers of fibrosis and kidney damage. And to give you, a parallel to that, is when we think about, diabetes, we know that we think about the omnius octet and the different core defects that are contributing to hyperglycemia. And we're going to tie this in towards the end when we talk about the medications. We're picking ones that have different mechanism of action. Same thing in hypertension. You're picking medications from different classes to help with some of these specific drivers that are contributing to it. And today's focus, and we're going to talk a little bit more about it, is around this inflammation and fibrosis. So with that being said, both Dr. Morales, Dr. Busch, in terms of kind of the, advances that we've had in chronic kidney disease, what's, the standard of care currently? And I know I parked a question earlier regarding, smoking cessation. What are the drivers of damage in these patients? And, the big question is like, where's the science at? What's the science telling us to do now? If you could maybe, Dr. Busch, start, and then we'll go to you, Dr. Morales.
Well, so there are lots of drivers, but certainly, you're going through some of the lifestyle things here, like exercise, nutrition, smoking. High blood pressure is a big ticket item. So if you have diabetes and high blood pressure, they multiply each other in terms of your risk for kidney disease. So keeping blood pressure controlled has always been important. And then it was found, as we'll review later on, in about 2001, that using a RAS blocker, at that time they used losartan and irbesartan as ARBs, that particularly, those were particularly beneficial to kidneys. So anything that lowers blood pressure is good, but those were particularly beneficial. Anything that's lowering sugar is good, keeping the A1C down. But as you'll hear later on, SGLT2 therapy as diabetes agents are particularly important. And obviously dyslipidemia would be important to treat as well. So these are all some of the key drivers that we could do something about besides lifestyle changes.
Dr. Morales, for you, it's probably very rarely that you see a patient that just has diabetes or just has hypertension. When you're seeing these comorbid patients, how do you process all these different things? And we heard the interrelationship that Dr. Busch just talked about. What are your thoughts? What are your approach, and how do you tackle, everything?
Yeah, well, it winds up being a juggling act for the most part, because now, from the point of the internist, we're not only dealing with the diabetes and the kidney disease, but we're also dealing with the heart and other organs, including the thyroid. But for the most part, if we do or are trying to curtail the natural history of chronic kidney disease, historically, ACE inhibitors and angiotensin receptor blockers, just like Dr. Busch just mentioned before, are the cornerstone for nephroprotection when it comes to managing hypertension and managing diabetes. The major strides that have occurred over the years really have been the evolution of the incretin-based therapies and also the SGLT2s, because, in a lot of these trials that were done specifically looking for cardiovascular outcomes, it was kind of noted incidentally that their progression of kidney disease was actually curtailed, which led to some studies that we'll talk about a little bit later on. But, once you're on an ACE or an ARB and you're on a glucose lowering therapy that's giving you a little bit of benefit and you still have impaired kidney function, well, you got to kind of scratch your head and say, well, what's next? Where do we go from here? How can we further prevent deterioration of kidney function? Because as we did learn from some older clinical trials, that even while you're on an ACE or an ARB, you're curtailing the progression of kidney function, but kidney function continues to occur even in their presence, which means that there is some residual risk that we need to tackle.
Sure. And thank you both for those responses. I'll go back to you, Dr. Busch, for one quick question. There's a lot here on this slide, right? We have to tell patients within a 10, 15, 20-minute visit to exercise, nutrition, smoking cessation, and then manage all these conditions that you see here. I know you and I have spoken, and in the past you said you've been spoiled because you have pharmacists. How have you used pharmacists to help kind of tackle this and divide and conquer?
So the pharmacist is in the room before I go in the room, and they do thoroughly spoil me. They have their checklist or their cheat sheet. When was the eye exam? Are they on a statin? Is the LDL at goal? Is it below 100 or below 70 if they have heart disease, or below 55 if they have diabetes and heart disease? Are they on an ACE or an ARB? Are they having a cough on the ACE inhibitor? So they know the drugs. There has to be a statin and have to be an ACE or ARB as a minimum in everyone with diabetes. That's in the drinking water of patients with diabetes. And then when they go into their diabetes drugs, not just I'm on insulin, how do you adjust the insulin? Sure. You know, when to my sugar, which sugar? You know, morning sugar, and when I want my sugar normal. Well, what's normal? You give the range to the patient. We usually tell them, you know, when you deposit your paycheck every 2 weeks, do you want to go to the teller and just say, what's my balance? Good isn't a number. If you want, you know, so our pharmacist knows, okay, we want morning sugar 80 to 120. They're on basal insulin at night. How do they adjust it to get the morning up to, down to, based on those goals? So they do a lot of the legwork before I go in. And then, as we said, the over-the-counter drugs. So they're critically important. And we've worked with PharmDs and pharmacists for well over 20 years. So I can't think of going to work without them. And those of you in retail, you could have a great impact as well. You see what the patient's buying. You see what they're eating. They could be buying a candy bar and buying their insulin at the same time, or taking an NSAID and they're on an ACE or an ARB. You could be saving their life and saving their kidneys by giving some counseling there.
Sure. Actually, I have a related question. So I have one, it seems like a retail pharmacist says that I don't have access to EHR records. What would you recommend as the best parameter for me to use in a pharmacy to screen patient profiles to see who needs to get asked about screening for both UACR and EGFR?
So so if they don't have the access to that, they can even ask them, you know, have they had their urine? You know, a lot of people don't like giving a urine specimen in a physician's office. When did they last have their urine checked? And empower the patient the next time they go in. Are you going to check my urine test? During the pandemic, a lot of women didn't want to sit on a toilet seat, so they didn't give a urine specimen. We are more likely to get men giving a specimen than women. So that hopefully that'll change, but we're going to see an explosion of kidney disease, just like heart disease, because people didn't get care over the last year and they didn't get all the tests that they should have.
Yeah, so that's a great answer. And so basically, you know, if you have a medication profile, you can tell the patient has diabetes, hypertension. Boom, you just ask that question. If you've had your annual screening, you don't, you know, basically need anything more than that. So thank you. The next sequence that we want to talk about, you guys both alluded to it, is the, you know, innovation that is starting to come about with agents that we previously hadn't had. I think the last innovation that we had in chronic kidney disease was losartan, maybe 20 years ago. And since then, here in the last 3 to 4 months, we've had multiple agents that have been approved. Before we go into that, what are some of the consequences of this MR overactivation? And, you know, Dr. Busch, we can start with you. Dr. Morales, if you want to add to it. You both touched on it a little bit. If you can go into a little more detail around that, Dr. Busch.
So as Javier explained before, aldosterone retains salt, so it raises blood pressure. But it was shown many years ago, I think in the 30s and 40s, where they gave a mineralocorticoid type substance called DOAC to lab rats, and they had a lot of inflammation and fibrosis that was found in their kidneys. So it leads to endothelial dysfunction, as you see on the slide. The key thing is inflammation and fibrosis, as we'll talk about later on with the mineralocorticoid inhibitor. That's another aspect of benefiting the kidneys by blocking aldosterone with a drug like that. So, but those are the key things: inflammation, fibrosis, raising blood pressure, as well as what, you know, remodeling of vasculature, endothelial dysfunction.
Okay, that's really helpful.
It's the bad guy.
Yep, and it wreaks havoc in many different places. So then, when we think about, you know, addressing some of these drivers, Dr. Morales, like what are things in terms of data and how clinicians do this clinically? You know, we, like I said, have agents that have become available to us recently, but previous to that, we really haven't. And so what are we doing to address some of these drivers?
Well, I mean, certainly when we're looking at these drivers of chronic kidney disease, I mean, we've been basically mentioning it all evening so far, and that is blood pressure with filtration pressure, glucose, and how fluctuating glucose or high glucose levels depositing within the glomerulus can actually damage the glomerulus. But some of the things that we've learned over the years, especially with the mineralocorticoid receptors and the role of aldosterone, is how it actually can contribute towards the inflammatory process within the mesangium and within the filtration system of the kidney itself that oftentimes drives fibrosis. Now, this has historically been noted before, particularly when looking at, as mentioned before, the rodents that were treated with aldosterone antagonism and even pro-aldosteronemic agents and its effect in terms of fibrosis. So it seems that, well, if we block the effect of aldosterone within the mesangium, then we can actually curtail the natural history and reduce some of that fibrosis that can sometimes occur as a consequence of overactivation of these receptors. So even though aldosterone is sometimes perceived as a good guy, and it is when you need it most, having him around too often and too much may not be all that beneficial. We want to curtail that level of activity a little bit down, tone it down a little bit.
Okay, that's really helpful. And, I can just tell based on the questions that are coming in that we have a really, sharp crowd on the line. I just want to show one example of a question that's come in that we're going to talk about here. Literally in the next slide is you've all talked about it. We're going to get into the section. I know everyone wants to talk about the agents. The question here was if all of this data shows, and I know we're going to go into it, that SGLT2, GLP-1s, finerenone, work to slow kidney disease, why aren't they being given to every patient? I know we're going to get into it, but I just want to show, how our audience is thinking as we go into talking about the renal protective mechanisms of some of these classes that Dr. Busch, you're about to walk us through. So we're already getting questions specifically about the agents. And so if you can keep that in mind as we go through the next slide here.
So to answer the question first, they should be given to every patient, but they're not. People get into bad habits. When Javier and I were house staff, it was, okay, control the blood pressure, but it didn't matter how you control the blood pressure. Control the blood sugar, lowering sugar, lowered kidney disease. But now we know how you lower the sugar makes a difference. So sure. On the next slide, we go into the 4 key types of medications that might be useful. So basically, well, let's start with the RAS blockers. So in 2001, we learned that RAS blockers benefited the kidney. And the mechanism, when you give a RAS blocker, think that I'm the glomerulus, like a balloon, and you have blood flow into the balloon and blood flow out of the balloon, or air in and air out. And the more pressure in the balloon, the worse. What a RAS blocker does is on the next slide, where it shows it dilates the efferent arteriole, or the blood flow out of the balloon. So you're getting more blood out, so you're lowering pressure within the kidney. Then what an SGLT2 does is an SGLT2, by urinating out sugar, salt, and water, you fake out the kidney. So the kidney thinks you're getting volume depleted, so it constricts the afferent arteriole, or the airflow into the balloon. So there's less air in, more air out. Or in the kidney, less blood in, more blood out, you lower the pressure in the kidney. So the RAS blocker is treating hemodynamically, and the SGLT2 is treating metabolically. Now we talked about mineralocorticoid inhibitors, and we'll talk about the new drug finerenone, and that drug blocks aldosterone, so that's lowering inflammation and fibrosis. So you can see a multi-pronged approach to benefit the kidney from a blood flow standpoint, from a metabolic standpoint, and now from an anti-inflammatory standpoint. And finally, the GLP-1s may have other benefits, maybe by receptors within the kidney or receptors elsewhere in the endothelium. It's known that they lower proteinuria, and we'll see in the future, do they actually prevent end-stage kidney disease as well? So we have lots of classes of drugs, very different than when we were house staff years ago, where it's, okay, lower the blood pressure, lower the sugar, but not how you do it. And now we have specific modalities to benefit the kidneys.
Excellent. And I can tell our audience is dying to get into some of the pharmacotherapy. We had another 6 questions come in regarding pharmacotherapy. So I know we're going to answer a lot of these questions. If not, we'll definitely get to them. And so why don't we go right into it? So I think everyone is eager to understand some of the efficacy and safety data for not only current, but emerging therapies for CKD. And so Dr. Morales, maybe you can start us off in saying, what are we doing right now, right? 6 months ago, 4 months ago, we didn't even have these new kids on the block that we're going to do a deep dive on. But what is the current standard of care?
Well, I mean, it's basically a moving target all the time. And the standard of care, if we're looking at different agencies like the American Diabetes Association, for instance, it's actually a living document that's updated on the basis of data that's reported in terms of outcomes. So if we're looking at patients with chronic kidney disease in diabetes, well, let's take a look at what the American Diabetes Association recommends. First is, as mentioned before, from a historical standpoint, doing RAS blockade with either an ACE inhibitor or an angiotensin receptor blocker, again, to create efferent arteriolar relaxation, which decreases glomerular filtration. And then in 2008, as we learned from some of the cardiovascular outcomes studies, which have subsequently led to specific renal-based studies to explore the benefit that certain glucose-lowering therapies actually have, the SGLT2s have basically proven the fact that they're beneficial at the level of the kidney. So now we're dealing with afferent arteriolar narrowing. We're dealing with efferent arteriolar relaxation, both in combination to decrease glomerular filtration and preserve that nephron. But what we're learning nowadays is that, that mineralocorticoid receptor overactivation still exists, and that fibrotic process within the kidney, which is also responsible for further deterioration, can be shut down. And if it is shut down or slowed down, it does offer renal benefit. So now the question is, should we be using a mineralocorticoid receptor antagonist as part of the standard of care on top of these beneficial agents? And is there an additive benefit that could be construed by using these drugs in combination? Okay. I'll tell you what, my bet is that it probably will, and it will offer some synergy, but we need more data.
And I'm going to come back to that question, because I know we have a few questions right around that same theme. Dr. Busch, we heard a little bit about kind of RAS blockade, ACEs and ARBs. When we think about, what residual risk we have, despite this, right? We'll look here in a little bit. I'm going to have you take us through the first trial, which is going to be the Credence. I'm going to have Dr. Morales talk about the DAPA CKD study. These are studies that are being done on top of standard of care at the time that they were conceived. So can you walk us through a little bit about that residual risk, and then start taking us through the first trial, which is the Credence trial?
So the week after 9/11 in New England Journal, there were 2 articles about RAS blockers. One was the RENAL study, and the other was the irbesartan diabetes nephropathy trial. And what they did in these studies is they gave here in the RENAL, they gave losartan, and in the other one, they gave irbesartan. And the punchline was you lowered, the primary endpoint was doubling of creatinine or end-stage renal disease, dialysis or transplant or death. And you can see on the slide, 16% lowering. Well, that's great, but 84% of people still went on to get kidney disease. So that's the residual risk. Similar, like when you give a statin, you might lower heart disease 37%, but 63% is still going to get heart disease. So you don't feel great if someone had a heart attack while on a statin, because you could have done more. Similarly here with kidney disease, they're on the RAS blocker, but that's not enough. Unfortunately, medicine has evolved a lot in the last 5 years, that we have all these great toys to play with. That's what keeps medicine fun for all of us. We get new things that we could do to benefit the patient. So the punchline of RENAL is you lowered events by 16%. terrific, but 84% of people still had an event on top of that. And that's why the new drugs we're going to talk about are important. So these drugs first were known to lower proteinuria. And then when they studied Renal with losartan or irbesartan diabetes nephropathy trial with irbesartan, that it was found that they benefited end-stage renal disease. So in general, most of our colleagues think, okay, an ACE or ARB should be in the drinking water of anyone who has diabetes if they have proteinuria or any kind of kidney disease or hypertension, because it benefits the kidneys.
So that's really helpful. And I think, we got the first shred of data, with the SGLT2 trials. And so if you can maybe give us a Cliff Notes version, we have, 4 or 5 slides here on the credence, and maybe even give us a little bit of reference of what patient population we're looking at from our Cadogi heat map.
Okay, so in credence trial, these were patients already on a RAS blocker. So you think, okay, you're doing everything you can. But despite that, they had a GFR 30 to 90. So as you can see on the slide here, they were between stage 2 and 3B on the vertical axis, 30 to 90. And on the horizontal axis, their urine microl was 300 or more. So there they are. 300 or more is the far right, and 30 to 90. So you could see they were either orange or red. These are patients who are at high risk of progressing to worsening kidney disease despite being on the RAS blocker. And those were the patients, half were given canagliflozin 100 and half were given placebo. And what they looked at is end-stage renal disease. So dialysis, transplant, or renal death or cardiac death, or they also looked at proteinuria dropping significantly. Those were the endpoint. It was a multi-endpoint type thing. And if you had one of those endpoints, you counted versus the patients who didn't have one of those endpoints. That's what was looked at. And the punchline of the study is here, 30% reduction. And look how early the curves separate. So they separated by the first year and they keep getting wider and wider apart. So the study was stopped. It would be unethical to continue the study when the curves are separating the more time. So this became standard of care, that canagliflozin was the first of the SGLT2s to show that it lowered end-stage renal disease. And then, that's what the credence punchline was. There were also a renal-specific endpoint shown on the next slide that also lowered kidney disease. And this, so 34% renal specific endpoint was dialysis, transplant, the creatinine, the GFR dropping, and renal death. They left off cardiac death here. So renal specific, major league drop, and look how early the curves separate again, very early on. And the next slide shows the subgroup analysis. So everything is on the side of canagliflozin did better. Didn't matter where your GFR started, whether it was stage 3B with 30 to 45 or 3A, 45 to 60, or even if your GFR was 60 to 90, it always benefited the patient. It didn't matter if they had a lot of proteinuria, over 1,000 or under 1,000, it benefited. So everything is on the proper side there, that patients who had urine microl, patient who had loss of kidney function with a low GFR had major benefit giving 100 of canagliflozin. This was a big deal, and this was only in patients with type 2 diabetes, to contrast what Dr. Morales would review with dapagliflozin's study. Oh, and the last thing is you could see right away on the left that proteinuria drops significantly right away. This was known when the SGLT2s were first tested as diabetes drugs, that you lowered proteinuria, but they couldn't claim it lowered end-stage kidney disease until they did the study. So they had to do a several thousand patient study, as we just outlined. Now, very importantly, as we will both show, I will and Javier will show, that early on when you give an SGLT2, the GFR drops a little bit in blue and stabilizes. So it drops a little in the beginning and stabilizes because, remember, you're urinating out sugar, salt, and water, so you're volume depleting the patient slightly. But then, as we said before, you're faking out the kidney so that the kidney thinks you're getting volume depleted and constricts the flow to the kidney, the afferent arterial, or less air into the balloon, so you're building up less pressure, and that's why it flattens the curve. So this is shown here. But importantly, as pharmacists and others working with us, don't let the primary care doc say, oh, I'm stopping therapy because the creatinine bumped a little bit. As long as the creatinine doesn't bump by 30%, the GFR drops a little, this dip is expected and shows the drug is working. Don't panic. So if the GFR drops a little and the creatinine goes up a little, as long as it's not more than 30%, don't worry. You're doing the right thing. You might have to do a lot of hand-holding to your collaborating physician to say the GFR is expected to drop, the creatinine is expected to go up. Don't worry. Over time, this will benefit the kidneys.
That's a
I
great
tell you,
point.
Bob, happens all the time, man. I see that all the time in some of the patients that I've treated with SGLT2 inhibitors. And oftentimes I'll get calls from some of the other subspecialists, particularly the cardiologists, because some of them don't really understand that there is true benefit that's exhibited there or because of these agents. And
Sure.
the decrease in GFR is certainly expected, sometimes a little bit.
The other call you always get is there's sugar in the urine. The OBGYN or the urologist, oh my God, your patient has 4+ glycosuria. Thank you very much. Hang up. And they don't know how an SGLT2 works. That's how it works.
Yeah, I know we've had to write letters all the time, especially for the civil service workers, right? The
Yeah.
bus drivers and the train operators, because it's just something that most people are not used to seeing. But
Absolutely.
for us, it's a good way to determine that the patient is actually taking their SGLT2, is
Yeah.
to see whether or not there's any sugar in the urine.
And that's a great reminder for our pharmacists that are in there. And, that's an area where, again, you can get involved and let providers know that it's transient in nature. And if anything, as we'll see here in the next coming slides, it's nephroprotective. And so, Dr. Busch, in your scenario, if, we're not checking that often, and so we would never even see that dip. This is only if you're, going to follow up in 2 to 3 weeks. And so if you're, booking out 3-4 months, you're not going to see that. And that's something hopefully that there's not a knee-jerk reaction to. So Dr. Morales, if you could walk us through how DAPA-CKD built on the evidence that we already knew about SGLT2s, because this was very unique. And if you could tell us what was, please.
Yeah, so taking a look, just like Dr. Busch had pointed out with the Credence study, I guess we should probably start by first exploring the KDIGO heat map as you see here. And in that gray box was the study population for the dedicated DAPA-CKD study, which looked at the piogliflozin and its effect on kidney disease. And you could see that square was a little bit wider and was a little bit higher. So this was a little bit less sick population of patients with kidney disease that was enrolled in this trial. But what's very unique about the study was the fact that it enrolled patients that did not have diabetes to see whether or not the nephroprotective effect of the piogliflozin was unique only to the diabetic or to all that were involved. And the study criteria, as you can see, is you needed to be over age 18, you needed to be on maximum tolerated ACE inhibitor or ARB, and the GFR was a little bit different because now we're looking at patients with a GFR between 25 and 75, but they definitely had evidence of microalbuminuria or proteinuria in the urine. And when we move ahead, when we look at the primary composite endpoint, which was doubling of the serum creatinine or progression to end-stage renal disease, we could clearly see, just like we saw with the Credence study, that there was a nice separation of curves that occurred between the placebo group and the dapagliflozin group that started within months of initiation of therapy in these data. And looking at this, it was a 39% reduction in the progression of those hard renal endpoints, which was really amazing. And what was even more amazing was the fact that there were patients enrolled in this study, and I'll repeat it once again, that did not have diabetes. And if we look at renal-specific composite endpoints, which looked specifically at the GFR going greater than 50%, progression to end-stage kidney disease or renal-related deaths, here we saw a 44% reduction. And again, within months of initiation of therapy. And this was highly specific, statistically speaking. And also, very important is the effect on the glomerular filtration. And as Dr. Busch mentioned before, initially there is going to be an anticipated decrease in glomerular filtration, which was largely driven by the volume contraction because of the diuresis that's induced by peeing out glucose, a little bit of volume contraction. But that decrease in GFR actually stabilizes. And as we look at the placebo group, there tended to be a continual decline in that glomerular filtration. Just like the Credence study, what was very important with the DAPA study was that it too was stopped early because of the benefits that was demonstrated by being on dapagliflozin. And if we're looking at this forest plot, looking at patients with or without diabetes, you could see very clearly here that all of these data points fell far to the left of that line of unity, favoring dapagliflozin, even in patients without diabetes, and even if your blood pressure was well controlled or even greater than 130. So this is actually really compelling and very powerful data. Now, I know many of you are realize that there is yet another SGLT2 inhibitor that's in the marketplace today. And that other SGLT2 inhibitor, being empagliflozin, is still in the midst of its renal study, which is yet to report at this point in time. So stay tuned for that one as well.
Excellent. Thank you so much. So Dr. Busch, now we have a couple differences here. Dr. Morales mentioned we have another one. Two of them are stopped early. One's still ongoing. Maybe that also gets stopped early because we're seeing something, very clear here. How do you make sense of this, and what are some of the differences that, if any, we should note and take away from here?
So the canagliflozin study, since it was the first one out, the FDA adopted it to say, okay, basically the criteria that got you in the study. You had to have type 2 diabetes, you had to have albuminuria, and the endpoint was doubling of creatinine, end-stage kidney disease, cardiac death, or heart failure hospitalization. That's CANA. Now, DAPA, remember, as Dr. Morales said, you didn't have to have diabetes. So look how the label differs. Here it says, in adults with chronic kidney disease, not in type 2 adults with nephropathy. And notice albuminuria is left off. Even though you had to have albuminuria to get in the study, I think the FDA is so impressed that this class prevents kidney disease that for DAPA, they didn't even require proteinuria. You could just have a patient with type 2 or without diabetes who is at risk for worsening their kidney disease because their GFR is low. You don't even have to have the proteinuria to initiate the drug. And yes, many of you pharmacists say, will the drug be covered in a non-diabetic? It is covered in non-diabetic, not only for this indication, but as an aside, it has a heart failure indication as well, with heart failure with reduced ejection fraction in a separate study. And that also showed renal benefit in that study. So the SGLT2s so far, both of them here, CANA and DAPA, showed renal benefit, but the FDA was more generous with the DAPA label because of the study. And also they even left off proteinuria. You don't have to have proteinuria. So those of you who are pharmacists working with clinicians, if you see a GFR that's low, recommend to your physician, where's the SGLT2 as part of their treatment plan? Particularly if they have proteinuria, you could give either one, but even without proteinuria, you could give dapagliflozin, and they don't even have to have diabetes. And what was shown in the DAPA study that Dr. Morales discussed, if you had pre-diabetes, you were less likely to go on to diabetes. That would be off-label use, but a lot of our colleagues do it in a pre-diabetic for a twofer. Not only you're preventing the diabetes, but you're preventing acceleration of the kidney disease.
No, that's awesome. That's a great reminder for the pharmacist that, what may historically been, a diabetes drug is now, multi-organ, multi-benefit drug. And you'll see this for other indications in a non-diabetic population. So Dr. Busch, while you have the mic, what about the GLP-1s? We've gotten several questions in regarding GLP-1s. Where do they stand? We saw 2 indications. Do we have anything here on the GLPs? So
the GLPs were all tested, as was said earlier, for cardiac benefit. And the 3 that are cardiac beneficial in their studies were the LEADER trial with liraglutide, the REWIND trial with dulaglutide, and the semaglutide in the SUSTAIN 6. They all have cardiac benefit in either secondary prevention with liraglutide or semaglutide, or primary benefit just for risk factors with dulaglutide. But notice the bottom there. You could see all these renal parameters that go the right direction. So in many of those studies, there's an implication that these drugs prevent end-stage renal disease, lower proteinuria, but they don't have the indication because the FDA mandates a several year study with 5,000 patients, half get drug, half get placebo, looking at the same criteria we looked at that Dr. Morales went over in DAPA and I went over with a Credence trial. So they're doing a formal study, which is shown on the next slide, called the FLOW trial. Mm-hmm. So actually, Novo is doing this study. We're in this study, so it was easy to recruit for. Patients who aren't on a GLP-1 before, they could be on any other mix of diabetes drugs, A1C under 10. They had to be on a RAS blocker. Notice in all these studies, you have to be on the standard of care with a mm-hmm. RAS blocker. And as you can see, the urine micral had to be elevated if the GFR was very low. If the GFR were higher, they had to have markedly elevated urine micral 300 to 5,000. So there's the KDIGO map. There's the study population. Again, easy to find these patients. So those of you who work with clinicians in the office, we have access to the database. Point out to your clinician, even though they're on a RAS blocker, even if they're on an SGLT2, if they have a low GFR and a urine micral that's elevated, point out they should be on a GLP-1 as well. And
excellent, thank you. And so I know that in the next couple seconds, and then I know we're going to get into the MRAs because we've got several questions that have come in about that. So then what do you do here right now? SGLT2, GLP-1?
So it's like you love both of your kids. You love your son and your daughter. What are you going to do? Well, if you did both, it's not so bad. So if you have heart failure or kidney disease, the SGLT2 takes priority. And then if you can't use it, or if you need extra A1C lowering, give the GLP-1. If you predominantly have ASCVD, because of the dramatic weight loss with the GLP-1, although SGLT2s, you lose calories in the urine, GLP-1, you lower appetite, we give a GLP-1 that has cardiac benefit. Those 3 trials we talked about, LEADER with liraglutide, SUSTAIN with semaglutide, or dulaglutide in REWIND. So you give a heart smart GLP-1 if they have just heart disease without kidney disease or heart failure. If they have heart failure or kidney disease, lead with the SGLT2. But I'm sure Dr. Morales and I use both of these in all of our patients. But that is not common. And you pharmacists who are filling scripts or pharmacists working on clinical ward, you're not going to see everyone getting an SGLT2 or GLP-1 like we both do, because we're into the field here. Many of our colleagues still use DPP-4s because they're easy to give, open mouth insert pill. GLP-1, you have to counsel the patient about nausea and injection. And SGLT2, you have to counsel the patient the various counseling issues about yeast infections and lowering the thiazide and other things.
No, that makes sense. And I think it touches on this next slide. And Dr. Morales, maybe is that some of the reasons why you see them being underprescribed that Dr. Busch just mentioned?
Yeah, I think there's many reasons why, but for the most part, I think is, the elephant in the room, which is going to be the insurance coverage and whether or not these medications are actually affordable. In the perfect world, however, these agents really are superfluous in terms of reducing risk. So, looking at this data, I mean, how often are they being utilized? And it's really appalling to see that this data that just came out in 2019, not that long ago at the time of the pandemic, 1.2 million people worldwide with diabetes were randomized to look at those with atherosclerotic heart disease and those without. And in those that do have atherosclerotic heart disease, it's appalling to see that only about 8% or 9% of patients are really using these agents that offer significant benefit. So certainly they are underutilized for various reasons. Sometimes it's basically pushback from the insurance company. Sometimes the patients might get a little bit perturbed by some of the warnings that may exist on the labels. And it's up to us to demystify some of these myths that they may actually have, or some of the complaints that they actually have, to make them feel a little bit more comfortable. But moving forward, aside from the GLP-1s and the SGLT2s that demonstrate renal benefit, is really the mineralocorticoid receptor antagonists, as mentioned before. And what we've learned historically is that overactivation of the mineralocorticoid receptors is one of the drivers that have been identified towards the progression of kidney disease and the progression to end-stage kidney disease. So when we're looking at antagonism of these mineralocorticoid receptors, we actually have 3 in the marketplace today. The granddaddy, or the parent drug, was always going to be spironolactone. Spironolactone has a long history. It works very well. It's been studied in many different trials. I think the one that comes to mind is always going to be the TopCat study, which definitely reduced history or hospitalizations for heart failure, although it was regionally based. And I'm not going to get into that right now. And it is a steroid-based mineralocorticoid receptor antagonist, with the challenge in particular with this agent being hyperkalemia. One of the concerns being hyperkalemia. Now, eplerenone is also a mineralocorticoid receptor antagonist, and it is also steroid-based and also demonstrated reduction in heart failure hospitalization. And what's very interesting about both of these agents, spironolactone and eplerenone, is that they both demonstrated reduction in albuminuria.
Sure.
But let's fast forward a little bit to finerenone, because finerenone, even though it's a mineralocorticoid receptor antagonist, it is a different type of an agent. And that's because finerenone is non-steroidally based. And because it's non-steroidally based, then some of the typical complaints that one would see with steroid-based mineralocorticoid receptor antagonism, being the gynecomastia and the hyperkalemia, is not entirely seen with the finerenone. Mm-hmm. Spironolactone and eplerenone basically have a much longer half-life, but finerenone is a smaller half-life. It's a shorter half-life. So as a consequence, not only are we seeing less gynecomastia or no gynecomastia or sexual side effects, but also we're seeing less hyperkalemia. And as you will see in dedicated studies that we will show you during today's presentation, offers a significant renal protective benefit.
Excellent. Thank you, Dr. Morales. And Dr. Busch, I'm going to kick it to you because I think you were in this study. So if you could go over the finerenone registration studies and some of the data that we now have. And I know the audience is eager. I have 4 or 5 questions related to finerenone that I'm just going to sprinkle here, and then maybe you can cover them as you go through. Some of the questions are, can we focus a little bit on the CV benefit related to the findings related to finerenone? There was another question regarding its dosing and if patients with low eGFR can take it. So as you go through the study population, if you and the next few slides, if you want to throw those answers in there as well.
So there's a pair of studies called Fidelio, which is the renal protection study with secondary benefit of heart. And then the sister study, Figaro, was the cardiac benefit of finerenone with the secondary benefit being secondary outcomes being kidney. And then they pooled the data. So I'll go over Fidelio and Dr. Morales will go over Figaro as well as the combination of everything, which was called the fidelity analysis. So Fidelio is only in type 2 patients. They had to have either a GFR 25 to 60 with a urine micral that's relatively low, 30 to 300, or if they had very high urine micral, they could go up to a GFR of up to 75. But notice the low end, 25. By the way, they all had to be on maximal RAS blocker. And if they weren't, there was a run-in period where you maximized the RAS. You could only get into the study if your potassium was under 4.8, because the worry, as Dr. Morales went over, was hyperkalemia. That would limit spironolactone or eplerenone being used because they have high rates of hyperkalemia. But as was pointed out, a non-steroidal like finerenone doesn't cause as much hyperkalemia. So basically, they had to be on a RAS blocker in maximal dose. They had to have a potassium under 4.8, although the label is now under 5. And they had to have microalbuminuria or albuminuria even higher than that without retinopathy. Or if they had very low urine micral, they had to have retinopathy. So look at the study population on the right on the KDIGO trial. They were mainly in the red and some in the orange. And you could recognize these patients. Remember, if they have an eGFR and a urine micral, point out this type of patient to your clinician that you work with if you're working side by side with a clinician, because you could save the patient's kidneys. By the way, in the study, 4% of the patient, only 4% were on an SGLT2. It wasn't yet the standard of care. But you could add this to an SGLT2. Even those patients, even though it was a small population, did have benefit, although we'll see with bigger studies if they have benefit with a combination. So an SGLT2 or a GLP-1, you could be on that in the study, but there were very few patients on that. So this was the setup of the study. And as we'll see the punchline, 18% lowering. So remember the residual risk you had with the rat, if you just used the Renal trial, we lowered at 16%, 84% still had problems. Here's an 18% lowering. I saw a paper, if you multiply this 18% times the 16% in Renal times the 39% in DAPA, you lower end-stage kidney disease by over 50%. So usually I tell patients, if we do this, we're going to make the nephrologist unemployed. They're going to have to do something more than dialysis because each drug, if they're additive together, now we don't know that yet, but the patients can be on a RAS blocker, can be on an SGLT2 from the previous studies, and now can be on finerenone. You keep dramatically lowering kidney disease on top of what they were on before. And again, it was a composite of end-stage kidney disease, dialysis, transplant, or renal death. So this was the 18%. And if they just looked at specifically, this was a secondary endpoint for a renal specific. The reason they looked at a GFR decline by 57% is this was a doubling of creatinine, a more traditional marker of kidney disease. It lowered events by 24%. And again, look how early the curves separate with this. So we showed you the 18% main renal benefit, 24% if it's just the renal composite itself, and there was a cardiac benefit in the study of a 14% lowering of heart attack, stroke, death, or heart failure hospitalization, I think is on the next slide. And here's a sub-analysis like we showed you before. So it didn't matter, everything was on the proper side that finerenone was better. So everything other than stroke did not go down significantly, but almost everything else, heart failure hospitalization went down majorly. MI, stroke, death stroke didn't, but MI and death did. GFR, all the stuff was on the proper side. That finerenone not only helped the renal benefits, but also the cardiovascular benefits as well, including heart failure hospitalization. So this is the Fidelio trial.
Excellent.
And finally, as you showed with the SGLT2s, you lowered proteinuria on the left-hand side, and there's the hazard ratio for a decrease of GFR by 40%, went down 19%. So major renal benefits using this, and now the label is you could add finerenone to a patient. You don't even have to have proteinuria at risk of progressing kidney disease as long as their potassium is under 5, because the worry would be hyperkalemia. And just so you know, if the potassium goes 5 to 5.5, you keep the same dose. If the potassium stays below 5 a month later, you could go up to 20 milligrams from 10 milligrams. If the potassium goes over 5.5, you stop therapy.
Okay, that's really helpful. And Dr. Morales, Dr. Busch just talked about Fidelity, which is this pooled analysis of Fidelio DKD and Figaro DKD. Can you maybe walk us through that and then a little bit about what the Fidelity analysis showed us?
Yeah, sure. So it's kind of interesting. The Fidelity analysis was actually a pooled analysis. So it wasn't really a dedicated study, but it was actually putting the data from the Fidelio and the Figaro study, both patient populations mixed together in a meta-analysis. So basically, the point of the trial really was to evaluate the relationship between the stage of kidney disease, the efficacy offered by finerenone, as well as the composite cardiovascular outcomes from this particular study. And what was really found was, if we're looking at the Fidelio DKD, finerenone slowed kidney disease progression, improved cardiovascular outcomes, as was shown a little while ago. And if we're looking at the converse study, which was the Figaro DKD disease, we found that finerenone reduced the risk of cardiovascular events in patients with mild to moderate kidney disease and type 2 diabetes. So if we're looking at the analysis results, here we could see that all of these data points compiled together basically led to a noted 14% reduced risk of composite cardiovascular endpoint. And this was cardiovascular death, non-fatal MI, hospitalization for heart failures. And if we're looking at the composite renal endpoint, which was doubling the serum creatinine and progression to end-stage renal disease, it was a 23% reduction. And if we're looking at these cardiovascular benefits across the board, it was basically consistent in terms of eGFR preservation and urine albumin creatinine ratio. And for the first time, if you look at this, how about this? A 36% reduction in the progression to dialysis if you have, chronic kidney disease. And what's even more important is the safety of the agent, because when we're looking at discontinuation rates related to hyperkalemia, it was only 1.7% of patients in the finerenone group compared to 0.6 of the placebo. Again, these were two different studies with pooled analysis.
So then where does that leave us currently in terms of differences? I think it was very kind of clear that, the older ones have these androgenic side effects. And so finerenone is obviously the new kid on the block with all the data. So what do you reach into your toolbox for at this point?
So as an endo, the only time I use spironolactone is in a transgender patient who doesn't want to have beard growth because of the anti-androgen effects, or someone losing hair to avoid anti-androgen effects. We don't give it to men because of gynecomastia and impotence. Eplerenone is indicated for patients who have heart failure after an MI. Spironolactone is indicated in the RALS study for heart failure with reduced ejection fraction, and also you can manage edema with it if you don't want to get hypokalemia from your loop diuretic. You could add this. But finerenone is the only one, based on the studies we just went over, that has the indication to reduce end-stage renal disease, a lowering of GFR, cardiac death, or the secondary benefit of hospitalization for heart failure with chronic kidney disease. You don't even have to have proteinuria. Just like the DAPA label was broader than the study, even though these studies you had to have proteinuria, you don't have to have it to do this if you want to prevent progression of kidney disease and prevent the heart failure as well. As an aside, one of the recommendations in the study was cardiologists to start doing urine micrals. Primary care and endos do it, but cardiologists don't usually do urine specimens. But what goes on in the urine would reflect you could lower heart failure by adding the drug. So they're recommending that cardiologists start doing urine micrals. So those of you who are pharmacists who work with cardiologists, recommend to them do a urinalysis, because if they find it, they might want to give finerenone in those patients who have diabetes and proteinuria.
No, that's excellent advice. Thank you guys both, and to the audience, for being so interactive. I have over 24 questions that have come in. We're going to do rapid fire here after we go through the audience response questions. And so get ready. So we're going to go back to the original question that we had, which was approximately what percentage of patients with type 2 diabetes develop CKD? So go ahead and key in your answer here, A, B, C, or D. So the correct answer is C. And you can see here, let's bring this up. You can see the pre-post results. And, Dr. Morales, if you want to comment a little bit, we talked a little bit about it being underdiagnosed. What do you think here?
Well, I think it's, the correct answer obviously is going to be 38%. I think that was the first slide that I showed in terms of screening. But I think that now that there's going to be more public awareness, I'm sure that number is actually going to go up. We're starting to see epidemic increases in diabetes for multiple reasons, including the obesity epidemic. And one can see the associated effect on the kidney as well. So,
awesome. Thank you. We'll go to our next one, which is which medication modification to SG's regimen would be most beneficial to delay the progression of eGFR decline and UACR improvement? Again, same options. Please go ahead and key in your answers.
Oh, wow. Look at that.
That's great.
You guys have done your job today. So this is great. So obviously the patient has ARB exposure. So addition of lisinopril doesn't make sense, changing from one SGLT2 to the other. And then obviously D, again, we're still in the same drug class. And so the correct answer is B. So thank you all for being very attentive this evening. And we'll go to our next question, which goes back to some of the pathophysiology. And the question here was, what is the postulated theory behind CKD related to diabetes? So go ahead and key in your correct answer. Excellent. Dr. Morales, what do you think?
I think it's actually quite good. Actually, in the midst of my talk, I was giving you a little bit of some of the pathophysiology of different causes of chronic kidney disease. So podocyte fusion obviously is what you see in nephrotic syndromes like minimal change disease. The mesangial contraction thing was basically the nonsteroidals and how they actually work to decrease GFR. But the obvious question with CKD related to diabetes is going to be the mineralocorticoid receptor overexpression and how curtailing that actually has significant benefit in terms of delaying the progression. So thank you to the audience for doing well with that.
Absolutely. And Dr. Morales, while you have the mic, I want to thank you both. I could spend another 30 minutes with you. I always learn when I'm doing these programs with you. What are some parting thoughts that you can leave the group with here as we kind of talk about, SMART goals is something that is relevant to me. We talk about it to patients. What would be the takeaway points here for our audience tonight?
So I think for me, the thing that I would basically say is, just like we're doing with diabetes, when managing glucose lowering, not to practice inertia. I think we should not be practicing inertia when it comes to kidney diseases as well. We have a great tool, great utility. Check that urine albumin creatinine ratio. Make that diagnosis earlier. Institute therapies earlier. And remember, even if there may be on a RAS, a lot of these studies that were done was already on a backbone of a RAS. And if you're on an SGLT2 and you have diabetes with chronic kidney disease, I don't think that there's a reason why you shouldn't be using a mineralocorticoid receptor antagonist on top of existent therapies. So please avoid clinical inertia.
Excellent. So we have some additional resources for you. So again, on behalf of all of us, I want to thank you again for joining us today. I do want to let our audience know to please visit cmeoutfitters.com for access to these resources and other certified educational activities. As you can see the link there. And to receive credit, make sure you complete the post-test and the evaluation online. I know you all took some time here, so we want to make sure you get the credit. And participants will be able to download and print their certificate immediately upon completion. So thank you to everyone. And I'm sorry we couldn't get to all the questions. We tried to answer as many of them as we could. We had a lot of ground to cover. And thank you all for joining and being very interactive with us. And thank you both again for being here with us tonight.